Welcome to the presentation on travel medicine, where our goal is promoting health and safety abroad. This is Dr. Stanford Ho, ASU Health Services. Let's meet our travelers. First, we have a 20-year-old female engineering student with intermittent asthma going to Ecuador for a few weeks as part of an Engineers Without Borders program, where she's going to help develop a safe irrigation system for a rural village. Then we have a 19-year-old undergraduate on Adderall and sertraline going to Dubai and then later on to China for a study abroad program. Then we have a 37-year-old type 1 diabetic, hypothyroidism, going to Madagascar for a 6-month graduate research. So I give you these examples not to break down the details of why they're going or their medical history, but to let you know what type of students, patients we see who go on travel abroad programs, what wonderful humanitarian programs are going on, as well as knowing that they do have underlying medical conditions that we need to consider and address, not only to reduce a flare-up of their conditions while they're traveling, but also to check with the countries to make sure it is legal and allowed to bring in certain types of medications such as controlled substances, injectables, and making sure they have the proper accommodations to store these, such as insulin with refrigeration. Why do we have travel clinics? Obvious reasons include preventive. We give vaccinations to help reduce illnesses, and we give them antibiotics in case an unforeseen illness occurs, such as traveler's diarrhea. We want to review their chronic medical conditions to make sure they know what to do in case something unexpected flares up during their travel. Education, to let them know what are their resources in case an unforeseen medical emergency occurs, and how to keep themselves safe, talking about street smarts. Then you talk about food hygiene, making sure they're protected against any kind of foodborne illnesses, as well as reducing their illness opportunities from mosquitoes and ticks. There are certain places that have requirements for their destination. Yellow fever is required in places in South America as well as Africa. If you do not have a yellow card with a stamp that documents a recent yellow fever vaccination, then you may not be permitted entry into a country, you may be deported, or you may have to receive a foreign injection with a potential quarantine period. Certain types of trips require vaccinations, such as Mecca for pilgrimages. They require an updated polio and meningitis vaccination to participate. Then you want to also assess their risk. Are they doing any types of high-risk activities? And certain locations may have risks dependent on their destination, urban versus rural. The World Health Organization estimates that international tourist arrivals worldwide at all destinations total 1.2 billion yearly. For our travelers, the main modalities of travel include flights, trains, and boats. What are the most common causes of injuries and death for travelers? The most common causes are pre-existing medical conditions. So when a traveler is about to embark on a trip overseas, we need to make sure that their cardiopulmonary fitness is up for the travel. If someone has an underlying cardiac disease or lung disease, it is more likely to flare up in a foreign territory than it is back in an environment that they're familiar with. Furthermore, if they're not conditioned to travel, things can flare up. Imagine someone who has underlying cardiopulmonary conditions, known or hidden, trying to rush through an airport with heavy luggage, making a flight, as well as climbing up temple-ruling stairs to see a sight in high altitudes. Those are conditions that can definitely flare up an underlying condition. For non-medical causes, motor vehicle accidents tops the list, and not too far behind that is drowning. So as you can see on the photograph on the slide, we have Southeast Asian photos of mopeds and motorcycles with seemingly no traffic lanes, and people are weaving back and forth. Luckily, they're all wearing helmets, which a lot of these places they do not. And right below that, you see an image of traffic zooming by. It is a red light for pedestrians, but yet pedestrians are crossing through nonetheless. A number of years ago, an unfortunate accident happened in Thailand where a student drowned from what we presumed was a riptide. So These things still occur, and they're unfortunate and tragic when they happen. So we should always educate our travelers to not ride motorcycles, be careful when you're crossing the streets, and always make sure that if you're swimming, that you're swimming in safe, marked locations with other people around to help you, and that you're not drinking alcohol. Inquire on the traveler's purpose and itinerary. What are they going to be doing while they're traveling? Are they going to be providing health care, or are they veterinary providers? This will allow you to consider vaccinations such as hepatitis and rabies vaccines. Are they going to be doing Peace Corps or study abroad, certain types of missionary work? Some of these programs have extensive forms to complete before they can embark on their trip. And these forms are not forms that can be completed with one visit. Sometimes they require lab testing. X-rays, they require multiple signatures from specialists. So those need prior planning. Ask about their locations. How long are they going to be there? When are they going? Is it going to be urban or rural location? Are there any excursions? For example, a student may go to Spain, but if you inquire, are you going to go anywhere else outside of Spain? They may tell you, why yes, we do have a weekend excursion in Morocco, which is a completely different risk category compared to Spain. What types of housing are they going to be staying in? Are they staying with a homestay family? Are they going to be staying at a semester at sea program, or a dormitory or a hostel? Are they going to be staying in hotels or apartments? Semester at sea, dorms, and hostels all have people living in close quarters. And in these situations, you want to consider meningitis vaccinations. What kind of activities will they be participating in? Are they going to be doing spelunking or cave exploration? Are they going to be staying in mainly agricultural rural areas, which can increase risks of certain types of mosquito-borne illnesses such as Japanese encephalitis? Are they going to be doing other high-risk activities such as cliff diving? Any prolonged sun exposures? The reason I mention the sun exposure is in malaria risk territories, doxycycline is an anti-malarial, but if they are going to be doing activities such as paleontology, archaeology, then they may be exposed to the sun for an extended period of time, and doxycycline would not be a good choice for them to use for malaria prevention. Are they going to be going to high altitude destinations? Will they need acetazolamide to reduce altitude sickness? And other things to consider would be seasonal risks. Certain places may have mosquito risks in certain times of the year, but in other times of the year, such as wintertime, they may not. Other places, 365 days a year, are mosquito illness risk as well as flu risks, such as in tropical regions in Africa and South America. Asking about travel insurance and medications. Do they have any type of emergency or evacuation coverage for their travel? Often insurances may have this clause. The ASU Aetna student insurance does have an emergency coverage clause, as well as any student that's participating in an ASU study abroad program, they may have this coverage as well. However, not all insurances will have this, and it may be worthwhile for a traveler to look into this option. Patients should keep their prescription labels and bottles intact with their medications. A physician note may be useful if they're carrying syringes or controlled substances. We had an example of a student who traveled to China. He was taking Zoloft, but he put all his pills in a pill box, unlabeled. Once he got to customs, they confiscated his medication because he couldn't document what they were, and he called in a panic to try to get a refill. So make sure you fill your pill boxes after you've arrived at your destination and passed customs. Otherwise, you may get difficulties entering the country. As discussed previously, some medications may be restricted or illegal. So controlled substances such as Adderall, Ritalin, narcotics, pain medications, benzos, those may not be allowed in certain countries. Some of them may have restrictions for a maximum of 1 month supply, and some may need special authorization for permission to bring into the country. Otherwise, if they do not check this in advance, they may get their medications confiscated, they may be incarcerated, they may get deported. So they need to find this out before they go. And also make sure you consider medication refills for chronic medical conditions, including emergency medications such as inhalers, emergency prednisones, EpiPens, emergency contraception, nitroglycerin, etc. Now let's move on to travel safety and street smarts. People should travel in groups when possible and be familiar with the local scams that they target travelers. The TravX report that we provide to patients does have a section on this and will give an update on what the local reports have been. We recommend for travelers to register at the travel.state.gov website for alerts. They can put their email in, and if there's any type of evacuation or terrorist alerts, they can receive an email from the government for this. Minimize any nighttime rural travel if it's not necessary. Crime rates increase at night, and there's more likelihood of getting into accidents if you're driving or riding a motor vehicle at night. Caution with electronics. Make sure to remove all your sensitive data that you do not need to bring with you on your travel. Consider bringing a track phone that's disposable. A lot of us don't realize that our whole lives are on our electronics. This includes laptops, smartphones, tablets. And once these items are lost or stolen, there may be a chance that someone can hack into it and there could be a risk for identity theft. So minimize bringing anything unnecessary with you if not needed. Don't display flashy wear or expensive wear. You're already going to stand out in many places as someone who does not belong there locally, and your mannerisms, the way you dress, make you stand out as a traveler. A lot of times the locals will consider that as an opportunity because travelers often carry money with them. So minimize any more exposure or any more attention to yourself by not dressing in a provocative or flashy, any type of attention-getting way. Use hidden or secure money pouches to store your passport and your money. These are often flat bags that have zippers that you can attach to your waist. Some people will like to wear them around the collars, but just make sure that you can secure and hide them by placing your shirt over it. This is not the same thing as a fanny pack. Fanny packs are on the outside. Your pockets are exposed to the outside. Backpacks and purses are on the outside. They're all grabbable, they're all snippable, and they're all pickable. So anything that's on the outside, you should not put expensive items in there. Also, keep separate copies of important documents, such as a photocopy of the main page in your passport, credit card customer service numbers. Keep those safe with you and also with a trusted loved one at home. In case things get lost or stolen, you have ways to get a backup. Call the credit card company to cancel and reapply for a new card. Always avoid getting anything that could introduce blood fluid contact, such as tattoos and needles. And we always recommend abstinence or at the minimum safe sex. The next section, we're going to talk about how to get to your destination safely while you're traveling. And this is mainly talking about flight precautions and DVT prevention. So general guidelines include wearing loose, non-restrictive clothing when you're traveling, especially for a prolonged period, potentially in a sedentary type position such as seating. Frequent stretches, flex, extend your legs to reduce any sedentary activity and improve blood circulation. Stay hydrated and minimize alcohol. Now we will be starting our second part of the presentation, vaccine and illnesses. Routine vaccinations. For all travelers, we recommend an updated tetanus, including a Tdap within 10 years, mumps, measles, rubella. All ASU students are required to show proof of mumps, measles, rubella before entering ASU, either 2 doses in their lifetime, a positive titer, or they can opt to sign a waiver if they do not want to receive this or there's a contraindication. Varicella should have the illness in their lifetime or 2 doses of the vaccination 1 month apart in the past. And influenza, we recommend yearly. Pneumovax or Prevnar for certain chronic conditions such as 65 years or older, underlying immunosuppression, chronic medical issues such as asthma. Meningitis vaccination. This includes ACWY, the traditional Menatra or Menimmune, and now we are also recommending to consider meningitis B. This is indicated for areas in sub-Saharan Africa called the meningitis belt because the local population may have periodic outbreaks during the dry season. This is also a requirement for pilgrimages to Mecca in Saudi Arabia. This is a recommendation for those that live in close quarters with a group of people, such as in dormitories, hostels, or semester at sea. For meningitis, the highest risks for travelers include those that go to sub-Saharan Africa along the meningitis belt. This is mainly during the dry season from December to June. As you can see on this map towards the right, the meningitis belt include those countries in the orange. There are sporadic epidemics in other parts of the world. This includes Saudi Arabia, which also has a requirement for proof of vaccination if you're going to be doing a religious pilgrimage into Mecca. And then, as mentioned, this is recommended for those who will have prolonged contact with a local population and those residing in close quarters with a large group of people, such as dormitories, semester at sea, and hostels. The two types of meningitis vaccinations include the ACWY and the meningitis B. There is a specific meningitis C available in Europe. However, ACWY should cover that. The duration of vaccine is expected to be at least 5 years, if not more. For the ACWY, we recommend age 16 or later to be an adult booster. And the ACWY includes vaccination types such as Menactra or Menimmune. Meningitis B should have at least 2 doses. Bexsero is a 2-dose vaccination. Trememba has an option for a 2-dose as well as the traditional 3-dose. There are precautions with polysaccharide protein conjugate vaccines, such as the Menactra ACWY, which has been reported to cause rare Guillain-Barré syndrome, which is also seen in other vaccinations such as the flu shot. Let's move on. What is the catch of the day? And this is going to be hepatitis. We're going to talk about hepatitis A and B. A brief overview. Hepatitis A is one of the most vaccine-preventable illnesses in travelers next to the flu shot. So there's no reason not to give a hepatitis A vaccination if a traveler is at risk with their itinerary. Common symptoms from hepatitis A and B infections include constitutional symptoms with fevers, malaise, anorexia, nausea, abdominal discomfort, dark urine, and jaundice. B, however, can be silent chronic. There are parts of the world, which include Southeast Asia, South America, and Africa, that have maternal fetal transmission of hepatitis B. So keep that in mind for your patients that may not have had hepatitis B screening, but may be from these countries at risk. Hepatitis A is acquired fecal-oral, and hepatitis B is acquired viral parenteral sources. The highest risks for hepatitis A is in less developed countries, such as Southeast Asia and Africa. And hepatitis B does have the endemic countries, as I mentioned, and these are the maps that show the distribution of the countries. As you will see with hepatitis A, this is going to be a common trend with the food hygiene illnesses coming up in the next slides. The less developed countries, which includes portions of Central America, South America, Africa, and Asia, had the highest risk. Your vaccine options include hepatitis A only, 0 and 6 months. This is a 2-dose series for lifetime protection. Hepatitis B, 0, 1, and 6 months. If they have had neither, you can give them a combination hepatitis A and B vaccination, a total of 3 doses at 0, 1, and 6 months. If a traveler will be leaving soon for an extended period of time and you want to give them maximum protection, you can opt for an accelerated schedule for the Twinrix combination, 0, 7 days, 21 days, and then their lifetime booster after they return 1 year later. Let's move on to traveler's diarrhea, our next topic. Typically watery, loose symptoms with frequent bowel movements and cramping. The most common bacterial etiology is enterotoxigenic E. coli, but it can be also viral and parasitic. Highest risks is in less developed countries. To reduce risk overall, we have always recommended diet hygiene education, which includes drinking from bottled, boiled, carbonated, or treated water, making sure the seal is intact in your bottled water, no ice, since ice is often made from tap water, staying with cooked foods that are served hot, nothing that's been sitting on a plate warmer or sitting around a street vendor in room temperature, and avoiding street vendor food. Even though it may be the tastiest with the local street culture, it is the highest risk, especially if there are standing condiments or their dairy products. We don't know how they have been stored or processed, so there's a higher rate for bacterial contamination. So our typical mantra is boil it, peel it, cook it, or otherwise forget it. How effective is this diet hygiene education? This is somewhat controversial. There are some studies that show that this may still be a little bit inconsistent in terms of efficacy. However, reducing your exposure to potentially contaminated food is probably not a bad idea. For travelers who are visiting friends and family, they also fall under a higher risk group for acquired traveler's diarrhea. Why is that? Often people who are visiting their friends or family, I'm visiting my aunt in Argentina. I'm going to go visit my friend in South America. They're going to take care of me. I won't get sick. They're going to be at a false, secure sense that whatever their host family is eating is going to be safe for them. However, their host family are used to the local food, but the traveler is not. So there is a higher chance that they may be reactive to what may have been safe for the host family to eat. So they'll be less vigilant to be a little more cautious about their food. If you do get traveler's diarrhea while traveling, the typical oral rehydration therapy includes something that contains some sugar, some salt, with water. World Health Organization suggests adding some potassium chloride, but it's not going to be easy to find when you're traveling, so often we'll just recommend something dietary such as bananas. So with the BRAT diet, bananas, rice, applesauce, toast, that will help improve hydration as well as reduce the symptoms of diarrhea and improve the resolution of the illness. For treatment of traveler's diarrhea, uncomplicated cases, if there is no aspirin allergy, you can consider bismuth subsalicylate or Pepto-Bismol, which does come in tablet form to make it easier to carry on travel. You can take this, a couple of tablets, before certain meals that a traveler feels is unavoidable, because there may be some bactericidal property to bismuth subsalicylate, although it is not an antibiotic per se. And you can also use it for mild cases of traveler's diarrhea afterwards, but be careful to not overuse due to the content of aspirin. Another option is Imodium or loperamide, but I always caution not use in full doses and to use it less frequently. Sometimes your body needs to clear an episode of diarrhea, and it can cause significant cramping if you end up using too much of this. If you do end up getting prolonged, which is more than 3 days, fevers or blood in your diarrhea, then you can consider antibiotic treatment. This includes ciprofloxacin, 500 milligrams twice a day for 3 days. However, there is increasing report of Campylobacter resistant to ciprofloxacin. So now the recommendation for many parts of the world include azithromycin, 500 milligrams daily for 3 days, or 1 gram one-time dose. The last option that is approved to be used is rifaximin, 200 milligrams 3 times a day for 3 days. However, this is a rather expensive option and very infrequently used for travelers. If there's persistent or worsening diarrhea symptoms, the traveler should seek medical attention, and we should consider other causes such as parasites. Moving on, who is this individual? The individual on the far left. Her name is Mary Mallon, and she has been known as Typhoid Mary. The historical details about her life: she worked as a household employee for affluent families in the Northeast, serving to be their housekeeper as well as their cook. And it turned out that there had been some outbreaks of typhoid a while back, and they couldn't figure out what the cause was. So public health did a surveillance, epidemiologic studies, and tracked down that Mary Mallon was a common link with a number of these families that got ill. And it turned out that she did not have the best hygiene, and she would go to the bathroom but wouldn't necessarily wash her hands thoroughly before she prepared food. So that's when they realized that she was a carrier of Salmonella typhi. She actually was asymptomatic, and she continued to spread this illness to people that came in contact with the food that she prepared. So I think the story was that she ended up being quarantined, and the rumor was that after her death, they autopsied her and found out that her gallbladder was filled with Salmonella typhi, but yet she still remained an asymptomatic carrier. And that's how they realized that food hygiene is very important to reduce the spread of Salmonella typhi. So typhoid. Spread by Salmonella typhi, typical symptoms include high fevers, headache, malaise, splenomegaly, flat rose-colored rash, and bradycardia. The highest risk is greatest in developing countries in Asia, Africa, the Caribbean, Central, and South America. And you can see the map that shows the areas that have the highest risks. Just to give you an idea of the incidence of typhoid in travelers, it shows you India, 6 in about 100,000 travelers, Pakistan, 9 in 100,000 travelers, and Bangladesh seems to be one of the highest ones at 21 per 100,000. So overall, not the highest number in travelers, but it is a significant illness, so it would be worthwhile to reduce the incidence. The mainstay of typhoid prevention include diet hygiene, and vaccinations include an oral live attenuated vaccine to be given every 5 years. It's 1 capsule every other day for 4 doses. This needs to be refrigerated and should not be given to someone who's immunocompromised. There's also the option for the intramuscular capsular polysaccharide to be given every 2 years. This is the one that can be given for someone who has a compromised immune system. Let's move on to polio. This is a viral infection spread through fecal-oral transmission that may affect the GI tract and nervous system, leading to paralysis, respiratory failure, and rarely death. Most adults who travel and contract polio will either be asymptomatic or may get mild flu-like symptoms and recover. The most devastating issues with polio are, of course, with the children, where they can get significant neurological issues with paralysis. There have been some outbreaks lately with polio, and as of the summer of 2017, there have been outbreaks in Syria and parts of the Republic of Congo. This is a requirement for vaccinations for those doing religious pilgrimages to Mecca, and there are certain countries that still have a recommendation for an adult booster if you're going to be traveling to an area at risk. Let's move on to cholera. This is an infection that causes profuse diarrhea spread by Vibrio cholera bacteria. It's spread via the fecal contaminated water, poor hygiene and sanitation, and poor water treatment areas. The symptoms include vomiting, profuse diarrhea with profound dehydration and electrolyte loss. The treatment is mainly IV fluids and supportive. There is a vaccine that's been available for quite some time outside of the United States, but recently the United States approved an oral live attenuated version of this vaccine in 2016 for ages 18 to 64. This is a single-dose vaccination that's reconstituted from a frozen state to be drunk at the visit. The duration of this vaccination effect is unclear. There are some studies, but the studies were done on the previous non-U.S. vaccinations, and the data shows anywhere from 6 months to a 2-year duration. And the drawback is that this vaccine can be quite expensive, upwards of close to $300 per dose. This vaccine cannot be prescribed at a pharmacy to be administered. It needs to be administered at a travel clinic by a medical provider. Let's move forward to our third part of the travel talk. We're going to be talking about mosquito illnesses. So the mainstays of education regarding reducing transmission of mosquito-borne illnesses include mosquito repellents, such as those that contain 30 to 50% DEET, showering just before dusk to reduce pheromones and avoiding scents, wearing longer sleeve clothing, pants, and lighter colors. It's thought that darker colors may attract mosquitoes more than lighter colors. Permethrin-treated clothing, bed nettings, and screens to reduce exposures. And to be aware of what types of mosquitoes bite when. So this includes evening risk with mosquitoes that transmit malaria, daytime and dusk risk with those that transmit yellow fever and dengue. Malaria is caused by the Plasmodium protozoa transmitted by the female Anopheles mosquito. This is probably the highest risk for morbidity and mortality of the tropical illnesses. And the common symptoms for many of these mosquito-borne illnesses include flu-like symptoms. For malaria, this also includes fevers, headaches, hemolysis, and jaundice, which leads to renal failure, seizures, coma, and death. To summarize a situation where a malaria-infected mosquito infects an uninfected host, the mosquito bites the person, then transmits the parasite through the bloodstream, which circulates to the liver where the parasites reproduce. Then it's released into the bloodstream, and an uninfected mosquito then bites this host and then subsequently carries the parasite and transmits it to another person. So this is why you can see any malaria infection is a public health potential risk depending on the types of mosquito in the area and the potential to transmit it to the local population. Plasmodium falciparum is the most dangerous of the 4 human malarial infections. Endemic risk occurs in parts of Central South America, island of Hispaniola, which includes Haiti and Dominican Republic, parts of Eastern Europe, Africa, Asia, Middle East, and South Pacific. In 2015, nearly 212 million episodes of malaria were reported worldwide, with 429,000 deaths. Most of this was in young children in sub-Saharan Africa. An estimated 1,700 U.S. cases yearly are diagnosed, mostly in return travelers. However, the majority of the United States travelers are able to get treatment, which is why our fatality rate in the U.S. is much lower than worldwide. It's estimated that costs due to illness and treatment and deaths from malaria are up to about $12 billion per year. For malaria treatments, the options include chloroquine for the non-falciparum areas. This is a weekly dosing medication. You take it once a week, 1 week before you get to the affected area, each week that you're there, and for 4 weeks after you leave the area, so that it can continue to take care of the reproduction cycle of the parasite in the liver. However, chloroquine is rarely used nowadays since most areas have the higher resistance with the falciparum strains. For those areas, your choices include mefloquine, which is dosed similarly to chloroquine once a week, 1 week before you get to the affected area, each week that you're there, and for 4 weeks after you leave. This may be the safest one to use in pregnancy. However, if you have someone who's pregnant, you may need to question why they're going to a malaria risk area, since that in itself can increase the risk for the pregnancy. This is contraindicated in those that may have underlying neurological conditions, such as seizures, any underlying major psychiatric illnesses, including anxiety, because this is the medication that has been anecdotally stated to cause the vivid dreams or nightmares in people that take it, although that may be overhyped. This also can cause prolonged QT intervals, so be careful with those with underlying conditions of the heart. As with Ciprofloxacin resistance, we are also seeing methylquin resistance in many parts of the world, especially in Southeast Asia. So methylquin is now no longer recommended to be used in certain areas such as Thailand. The next one that you can use is doxycycline. This is a daily medication. You start it 2 days before you get to the affected area. You take it each day that you're there and for 4 weeks after you leave. As mentioned previously, doxycycline can cause sun sensitivity, so be careful in those that may have extensive exposure to sun and use sun precautions, including sunscreen, clothing, and hats. This also can cause esophagitis. We've had some travelers that have come back with significant heartburn symptoms after taking doxycycline. The last one is Malarone, which is the progranil atovaquone combination. This is our preferred one if possible. However, it is the most expensive. This is a daily dosing medication a couple of days before you get to the affected area, each day that you're there, and for 1 week after you leave, because it actually clears the liver stage of the parasite reproduction. So this is preferred, especially if they're going for short trips to malaria risk areas. That way they don't need to take a 4-week course after they leave that area. The last time I checked this, about a month's supply of this cost about $150, so it is quite expensive, and there's limited data on the safety for more than 3 months of continuous use of this, so we have not been using this regularly for longer than 3 months, whereas the other ones are a little safer to use for long term. There are still questions about whether a student or traveler going to an area for longer periods, such as a 6-month to 1 year travel, should they take malaria prevention medications, or should they just take medications to treat malaria in case they get the illness? Because the locals don't take malaria prevention illnesses if you live there. So the question comes, why would you take it for an extended period of time? There's no right or wrong answer on that one, but it is something to discuss individually with your traveler. For those areas that may contain Vivax or Ovale Plasmodium, you may want to consider Primaquine, because that may be the most effective treatment for those strains. For you to use Primaquine, you need to consider checking a G6PD, because if they are deficient, it can cause hemolysis. As mentioned just now, there are students or travelers that go for extensive trips, and often we will give them an additional curative treatment for malaria if they're going to be remote from any medical facilities. We educate them on the symptoms, on what to look for to take the malaria treatments, including flu-like symptoms, and that way they know if they develop these symptoms to go ahead and take the curative treatment, but they still should try to get medical evaluation as soon as they can in case they do not get better. Moving on, this is a historical photograph of a 1905 Panama Canal quarantine station. This is a quarantine from yellow fever. Yellow fever is a flavivirus infection transmitted by the Aedes aegypti mosquito. It can cause self-limited febrile illness, flu-like, with hepatitis, jaundice, and sometimes leading to severe hemorrhagic fevers, renal failure, and death. In the late 17th century, yellow fever did appear in the United States with major epidemics from 1793 to 1905. Epidemics affected mostly eastern seaports and Gulf cities, killing hundreds up to thousands in a single summer. During the Spanish-American War of 1898, a group of U.S. scientists stationed in Havana, Cuba, led by Army medical scientist Dr. Walter Reed, discovered that yellow fever was spread by a mosquito vector, not from person to person. So, as of today, yellow fever continues to occur in tropical regions of Africa and portions of South America. This is a rare cause of disease in travelers. However, it is a fairly significant cause of morbidity and mortality if you get the infection. It is a requirement for entry into some countries, or you need to make sure you have some documentation to sign a waiver if you're unable to receive the vaccination for any reason. This vaccination is approved for 9 months or older, no pregnancy or immune suppressed patients, since it is a live virus, and it is now considered to be a lifelong protection in immune competent individuals, showing that immunity response can still be detected 30 years after the vaccination date in many individuals. As of spring 2017, the current U.S. yellow fever vaccine is no longer being produced due to manufacturing issues. A European version called Stamaril will be available in the interim until the new supplies are available, which is anticipated to come back around mid-2018. It is unclear the pricing of the Stamaril, and there are only certain authorized travel vaccine clinics in the United States that are authorized to give the Stamaril vaccine. Passport Health is one of the few in Arizona, Phoenix area that are allowed to give this. Moving forward, this is a public health flyer written in Chinese characters. This is posted in Hong Kong, and it talks about the Culex and the Aedes mosquitoes transmitting Japanese encephalitis and dengue fever. The reason I added this slide is to show you that Japanese encephalitis doesn't mean that it's just from Japan, but the main parts that are affected are Southeast Asia. Probably one of the largest areas of involvement include India. And this is public health informing the population to keep an eye out for standing water mosquitoes, to let the public health officials know if they see this so that they can eradicate it from the environment to reduce mosquito spread. Not too different from what we do here in Arizona regarding West Nile virus as well. For Japanese encephalitis, this is a flavivirus infection. It's spread by rice-breeding mosquitoes. Pigs and birds are the natural hosts. Symptoms include fevers, headaches, neurological involvement, with manifestations such as stupor, coma, seizures, paralysis, and death sometimes. Mortality, this is not the best data, but the ones that I've seen online show that the mortality rate is anywhere from 0.3 to 60%. Of those that are symptomatic, a third of them will die, a third of them will permanently be disabled, and a third will recover. However, to put this into context, typically for travelers, there's less than one case per 1 million travelers that actually acquire the infection with manifestation of these illness symptoms. So to describe this to a traveler, what I usually tell them is consider this similarly to West Nile virus. Very few people will get the actual illness, but if you happen to be the unfortunate person that actually gets the illness, the mortality and morbidity risk may be quite high. The distribution for Japanese encephalitis occurs along the eastern, southern, and southeast Asian countries, mainly in rural locations, such as those with flooding, irrigation, and rice paddies, with seasonal outbreaks in these areas. The vaccine is recommended only for extended stays in affected areas or travelers that have high risk of exposures, such as those that are camping in these areas, hiking, they're studying agriculture, etc. This is an inactivated vaccine, and in 2009, the previous vaccination that had higher hypersensitive risk was replaced by a safer vaccination called Ixiaro. So this is made by purified inactivated tissue culture from Scotland. And this dosing is 2 doses a month apart. One dose confers about 40% protection. The second dose confers probably up to 2 years of protection. They don't have quite good data on how often to boost, but the recommendation is consider booster in 2 years. This is a very expensive vaccine, so it runs about $300 per dose. So if insurances don't cover this vaccination, which many insurances do not cover travel visits or travel vaccines, it can run $600 for the complete 2-dose series. So make sure your students or travelers know about this in case there may be a bill after this vaccination. Let's move on to other mosquito viruses that we don't have vaccinations for, so I'm going to run through this briefly. For dengue fever, it can cause hemorrhagic bone-breaking fevers. That's one of the classic symptoms for dengue. Retroorbital headaches, arthralgias, and rash. A previous infection of dengue may actually worsen your response to the next infection. There's thought to be at least 4 types of, or 4 strains of dengue, and if you get one, it does not protect you against the other, and a second infection may actually increase your risk for severity. If you're suspicious of dengue, do not give NSAIDs because there is a higher bleeding risk associated with dengue. Chikungunya can cause arthralgias, which is a hallmark of this illness. Also, other symptoms include headaches and a rash. A previous infection is thought may be protective. So let's move forward to the next topic, which is rabies. An acute progressive fatal encephalomyelitis caused by a neurotropic virus in the family Rabies. This disease is almost always transmitted by an animal bite that inoculates the virus into the wound. It is found on all continents except Antarctica, and in certain parts of the world, canine rabies remains highly endemic, including but not limited to parts of Africa, Asia, Central and South America. For travelers with extensive unprotected outdoors exposure, such as those doing biking, camping, hiking, or they're engaging in certain occupational activities, may be at higher risk even if their trip is brief. So the occupational activities including handling animals, they're veterinary providers. Children are considered at high risk because of their tendencies to play with animals, and then they don't report bites. So then you miss the opportunity to get the vaccination on time, since the child may feel that they may get into trouble if they report that they played with an animal and got bitten. Casual exposure to cave air is not a concern, but if a caver is going to be doing extensive activities in the cave, you need to assess that risk, and they should be warned not to handle bats. The rule of thumb really is just don't pet any furry animals. Unless it belongs to a host family, is domesticated and vaccinated, don't pet them, because if you do get bitten by an unprovoked animal and it breaks skin, then you're obligated to get to a major medical center within 24 hours to get your vaccinations. Any animal bite or scratch should receive prompt local treatment by thorough cleansing of the wound with copious amounts of soap and water. Rabies pre-exposure vaccination should be considered for those at higher risk, such as veterinarians, animal workers, field biologists, spelunkers who are actually studying stuff in caves, and those who will be staying at rabies risk areas located more than 24 hours away from a reliable vaccine. Post-exposure vaccination includes a rabies immunoglobulin to be given at the wound site and at other areas, but not in the gluteal area, since it's thought to be that's the least effective region to inject. Plus 4 doses of scheduled vaccination. Or if they previously received the vaccination, then they should receive 2 doses of vaccine 3 days apart, or an alternate dose is 4 doses on the same day. That concludes the travel talk. Thank you for listening. Welcome home.